Hey guys, Katie Kleber with the FreshRN Podcast here with part 2 of my interview with Annabeth Davis and Morgan Melancon from St. Jude's Children's Hospital in Memphis, Tennessee. So last week we chatted about their unique nurse residency program, but then in this episode I asked them very specific questions about oncology nursing. Now, onco is not the only thing that St. Jude's provides, but it is a large aspect of their patient care. So I asked them questions like, what do nurses find challenging about working in oncology, and what do they really like about it? What are some nursing specific tasks that they have to that are very common in that patient population, as well as what kind of additional education and certifications are necessary to give chemo, to do some of the unique care that they provide. And their answers are just so fascinating, and I thought you guys would really appreciate it. So let's dig into the episode, people.
Yeah.
Now, I've been asking you all about residencies, but I was also wanted to ask you about oncology because that is so specific to St. Jude. Now, help me in because I'm not in Memphis. I'm not as familiar with the organization. Is the entire hospital all oncology, or is there a I don't want to say normal, a non-oncology like pediatric unit?
So we're all pediatrics, although we do have older patients we follow our patients for a long time. So you might have a 42-year-old coming in for a follow-up visit post, but generally all pediatrics. We started as oncology, but really to kind of encompass everything, we do catastrophic diseases. And so we
Oh,
do oncology, we do hematology, we do infectious disease. We're just about to start neurodegenerative diseases.
oh, wow.
So if it's a catastrophic disease, we are probably on our radar.
That is so
Um,
interesting.
yeah, no, it's super cool. Yeah, we have a huge HIV clinic and a huge sickle cell program. So it's not all cancer and all oncology. That is most of what we do, but we also have some other really large programs as well.
Wow, that's so interesting. Now, let's say a nurse wanted to work oncology. Do you need specific sort of I know you have to get checked off on certain things just to be able to give chemo. And I'm very not at all familiar with the pediatric side of chemo and oncology. But compared to like a regular adult med surg nurse, like new grad, what additional like training certification stuff is necessary for that new oncology nurse in your organization?
So I think one of the biggest things is that initially when they come in, we provide them the training that they need. So for one example, we have all of our residency sessions are oncology based essentially. So they get a lot of those skills in residency that can translate to their practice because all of our units essentially touch oncology in some way. One of the biggest certifications that they get pretty soon after they arrive here is AFON. So that allows them that chemotherapy and biotherapy administration course, and they're able to administer that chemo and biotherapy. And it's a 2-day course that we partner with and provide that here on campus. So that's one of the initial things that all of our nurses at St. Jude participate in, including our new grads. And that kind of kickstarts the certification process. Certification at St. Jude is huge.
Yeah, really big.
I don't know the exact percentage, Morgan may know, of how many nurses here are certified, but basically our motto is if you are not certified, you have a plan to be certified. Um, Yes. So most of our nurses are CFON, which is pediatric hematology oncology nursing. If you do work in a more specialized area like the operating room, most of those nurses have CNOR, so certified operating room nurse, or Kappa CPAN for those PACU areas. Bone marrow transplant has their own. So really whatever specific specialty you have, we encourage the nurses to get that certification. But the overarching theme is pediatric hematology oncology.
So is that you need to work here for 2 years or have about 2 years of like clinical experience to be able to take an exam and then you have your certification?
Correct. Yes. So everybody does AFON right after they onboard. And then I think the requirement's like 2,000 hours or something like that you have to work in order to sit. So normally it's within like first 2 years. But yeah, we provide really great certification resources. We'll pay for courses. We'll pay for you to take the exam more than once, actually, which is really helpful because test taking can be difficult for people. But yeah, that's something that is really, we have such a fragile patient population that I think getting people on board with being the best that they can be is not super difficult for us to kind of encourage that.
Yeah, we
not
encourage top of
unreasonable.
license.
Yeah.
Yeah. That makes so much sense. And if I've noticed in hospitals and units, because it's such a team mentality, if a few people, especially informal leaders, are getting certified, people are going to start getting certified. But if those informal people, or if it's not like the culture, then people aren't going to do it,
Oh, yep. 100%. Yeah. We have 100% of our nursing leaders are certified. That's a requirement. And then we're well above the benchmark when it comes to the rest of our certifications. But we kind of kickstart the process post-residency because their graduation gift is actually the exam, like core curriculum for whatever their specialty is. So yeah, so if they're an ICU nurse, they get the critical care core curriculum that helps them study for the CCRN. For BMT, they get the same thing, or we give them the pediatric oncology one for all of our other nurses. So yeah, we like to kickstart that.
Yeah, that's really helpful because I think when people do decide they want to get certified, then they kind of have to take it upon themselves to find a good review, maybe pay for it out of pocket, and they're kind of flying a little bit solo until they can just provide their new credentials to their unit instead of like really being invested in the process.
Definitely. Yeah. No, we're good about providing those resources and helping people get to that point. So yeah, that's something that's really, we're really lucky to have that ability.
Yeah. Now with oncology, like I've floated to adult onco, but I never worked peds. Certainly never worked pediatric oncology. But what are some things that nurses tend to like love about the oncology realm? And then what are the areas that maybe people struggle with or maybe leave because of or that are just really challenging?
I think things that they love for here at St. Jude, our patients are getting treated for months and years at a time. I think the average length of our leukemia protocols and treatment is about 3 years. So you are with these patients for a very long time. So I think nurses really treasure the relationships and that patient and family interaction that we have because the level we have of that here is very unique to oncology and then pediatrics because you get to have that quality time with these patients and parents and families. And that in turn helps you as a nurse, right? Because you're able to establish these bonds, you're able to anticipate needs. And so it goes a long way for both the patient and you as the nurse. As far as challenges, I mean, we do have a lot of end of life. So that's something that we have to be very cognizant of. We have a whole session in residency that's around it. So it really helps provide some context to the physical, tactile skills that they need to know, as well as the human skills that come with preparing for that situation.
Definitely.
Yeah, I can't. Oh, the like end of life, I could do that with adults, most adults. But the younger they are, the harder it was. So like, I would, if I was hired there, man, I wouldn't be like, I need a lot of,
especially we have a lot of resources here that help.
Yeah, we have a ton of resources through residency, but also for every nurse here. We have a huge resilience program, and we do a lot of different things through our Living Well Center that really support the mental health of nurses, because that's really, you have to take care of yourself in order to take care of other people, especially, pediatric patients.
Yeah. Yeah,
So,
especially like as I became a parent, like my ability to take care of adults changed, like my perspective changed. So then like, looking at kids it just differently, because you just understand it differently once you've, had kids. It just, man, brought it to a whole nother personal level, I think, which made I really need to adjust my boundary, my empathy bound. Like I want to be able to empathize without like sacrificing myself, right? Like, 'cause I have to do this all the time. So it's good to know that there's like support out there, but I'm sure that it is definitely a big challenge with the end of life.
It is. The good thing is that it's more happy than it is sad.
Mm-hmm.
That's probably the biggest thing that I hear, I bet every day you go to work and it's so sad. And it's actually not. It's
No.
super happy.
It's like Disney World.
It is. Seriously, there's bright colors and
It
fun
really is.
things. And we have 3 facility dogs that are St. Jude employees.
Oh my
that
gosh.
are always around. Oh my gosh, it's amazing.
Mhm.
Yeah.
Are they called dogters?
Oh my God, they
that would
should
be cute.
That'd be so cute.
They do have little employee IDs. So.
Yeah,
have
they
you
do. They have
seen
badges.
the Instagram dogter?
No, but I'm totally gonna have to look it up now.
Just look it up, dogter. It's like I can't remember what hospital it is, but it is a therapy dog at a hospital that has its own Instagram account.
That's amazing.
That's
Hilarious.
so funny. Yeah, ours are golden retrievers, and so they call them the Golden Girls.
Stop.
Yes, it's so cute.
Oh my gosh.
And we have 2 that are focused on patient therapeutic approaches, and we have 1 that's dedicated solely to employees. And so that's one of our resilience things that we do. So if a unit is having a really bad day, or you're going to have a really hard conversation, you can call up Rosalie and be like, "Hey, can you come to my bedside?"
Oh my gosh.
And yeah, it's awesome.
Mhm.
So
I'm going to call her on my day off.
yeah,
That's incredible. I've not heard of a hospital having a therapy dog specifically for staff.
It's a really great resource. And they are, you see them everywhere. So they're out and about. They come to residency sessions. They are eager to show off and be there when you need them. So it's really awesome.
definitely. 100%.
So what are some let's pretend talking to a nurse who's never done any oncology and didn't have any bedside experience. What are some specific tasks or procedures that would be specific to oncology that oncology nurse is going to be, I'm thinking ports, things that they're going to have to do that's different and that might be helpful to know ahead of time.
So I think there's a lot, because not only are we oncology, so there's straight up things for oncology, ports, chemotherapy, but we're also pediatric oncology at another layer, and then we're research pediatric oncology. So that just brings a whole new level of different tasks that you're going to have. Protocols is probably the biggest one. That's something that only really a research oncology nurse would have interaction with. And it's essentially a 300-page document that says this is how you treat this patient. But you as a nurse need to know what that document says, because it might say you need to draw this lab 6 hours before you give this dose. And you need to know it could be a really detrimental thing for that patient if you as a nurse don't know that you need to draw that lab. So you have to be really well attuned to being able to read through protocols and look through things. And that's something that is, I don't think you would find that in any other area of nursing. Annabeth could probably speak really good to regular or day-to-day tasks.
Yeah, it's the protocol is a big one because, like Morgan said, we are research-based. So most of the treatment plans that we provide for our patients are in research. So we have a clinical trial, if you will, might be the better layman term, on how we approach this patient. So, these are the chemo drugs. This is our plan of action. And then the nurse is responsible for being able to interpret that information and all of those crazy word jargons that are in a research protocol. And then, practice those tools at the bedside. So we do a lot of training around that. It kind of becomes an art of navigating a protocol. So the nurses are pretty familiar with, which ones are currently ongoing. They see them every single day, every single patient. So they get very, very good at reading one, understanding one. And so that to me is a big portion of what our nurses do every day. Like you mentioned, other kind of tactile skills. We have a lot of ports. We have a lot of central lines. Our nurses manage that 100%. We do have a vascular access team, but our nurses are the primary go-to when it comes to, getting in the line, flushing the line, troubleshooting the line. So our nurses learn all of that and are very good at what they do when it comes to our central lines. We also have a lot of unusual medications. So we do a lot of immunotherapies. We do a lot of antigens, cell infusions. So a lot of really cool medication administrations. We have some that are just, study drugs because we're doing everything we can to help this particular child with this particular diagnosis. So it may be a really unusual medication. I know one time I gave one and it was so fresh that it was literally just a bunch of numbers and letters for the name, and it was bright green. And it was so interesting because you're like, what is this? But you look at that patient who needed it, and it was so such a cool opportunity and experience to be like, wow, I'm like giving something that's like potentially going to really help this patient because he needs it. And it was super cool to like get the opportunity to do things like that here. And so nurses are very well involved in those processes. We have protocol committees that nurses sit on, so they're very involved in the translation of that from, the research aspect to the bedside. So they're very well equipped to handle that and translate that information to the bedside.
Yeah.
Wow.
Thinking of just other things that you would experience in oncology versus other ones, a lot of procedures, doing bone marrow aspirates, things like that, cell
Lumbar
collections,
punctures.
Lumbar punctures, all the sorts of things that come along with radiation oncology too. We do a lot more sedation in oncology than probably any other specialty. Probably more in pediatrics, but because a child isn't going to be able to sit there for 2 hours and get radiation on their head. So we have to sedate them for that procedure. So
so being very well equipped. Being very well equipped for that. And then we'd also have to sedate for imaging. So not only for radiation, but if they have to have a really long MRI or a really long PET scan, some of these little bitties, who can't sit still, we have to sedate them to make them a little bit more comfortable. So there's a lot of imaging that's involved, a lot of coordination with those departments. So a lot of coordination for that inpatient nurse to communicate with radiation or for a scan and, being able to take your patient to and fro. So there's a lot of that happens here that's involved in their treatment plan.
Yep. I think one of the biggest things for me that I never would have thought about coming into oncology was kind of the ancillary things that you have to do for the side effects. So, for example, there's this one medication that you have to give a certain bath to the patient every 6 hours. And like you will wake them up at night to give them a thiotepa bath.
Yeah. It's excreted through the skin. So you have to be able to bathe them to remove it.
Yep.
Oh my gosh, the skin gets like irritated?
Yes, really irritated. Or there's another one that you have to get them to void every 6 hours because their bladder will get really irritated. There are some patients that cannot have anything but sterile ice. You can't just get ice out of like your filtered ice maker. You have to literally make sterile ice. I never would have thought that would be something I'd have to do.
A lot of our meds they have to be administered through cold therapy. So like we have to have a child while they're getting that infusion, like have a popsicle or drink a slushie because we are trying to protect their mouth from mucositis. So they have to be having something cold. So like a little baby who, doesn't want a popsicle, we would like dip it in cold, do anything you could with a passy to help keep their little mouth cold while they're getting their infusion. So anything like random things like that you have to think of because these chemotherapies are, so toxic and you don't think about that. It's interesting looking at peds if new nurses are trying to decide between pediatrics and adults. Like Morgan said, this is not sad because pediatrics are so resilient. They come into the infusion center, they walk in outpatient, they get about 5 different chemos, and then they walk right back out to the cafeteria where an adult would be in the bed for 2 weeks. And so it is so rewarding to see like, they just pop right up and they're cool with it. And they're just a normal kid and coloring and listening to music or playing the Xbox while they're getting 5 chemos that I'm looking at trying to interpret, oh my gosh, what do I need to be monitoring for this patient? And they're just over there like reading a book.
That is kind of crazy because you would think, the more intense the meds I'm getting, like I'm going to see immediate results or impact on my patient. And you could give all these like really intense things simultaneously and they're just coloring a Paw Patrol picture.
They're just hanging out.
And sometimes, there are things that happen, as a nurse, you have to be prepared. So, they can have a reaction. They can have these things. But, the bright side of it is most of your day, your patient is going to just be a normal kid and you're just giving them some medicine through their buddy or their port or whatever they want to call it. And then you send them home.
Now, are you having nurses, like, will nurses float between those more infusion center kind of like more like outpatient vibey kind of areas, also to inpatient, or are those nurses in like, or is there no floating between those two?
So technically all of our nurses could float because they're all chemotherapy certified. So they could go to the infusion center. Infusion could come inpatient. We didn't really do a whole lot of floating between large departments. So, our surgical services or our inpatient or outpatient until COVID really.
Oh, yeah.
And then we saw more of inpatient nurses having to go help out in infusion center. And we thought that would be, or Annabeth, I think, was working there when this happened. But from my perspective, we thought that it would be really difficult. And it actually, like, people were having a lot of fun going to the infusion center. And
yeah, it's we have a lot of inpatient nurses that are, quote unquote trained to come, and they can, they're officially cross-trained to help out like in the infusion center. And we have some infusion nurses who could potentially go inpatient. That's really about our only cross, I would say. We do have a float pool. So they are a physical nurse. They actually are trained to float multiple departments. But we do have nurses that just can do whichever because they've been here for a long time and are very well equipped to kind of bebop inpatient, outpatient. Surgical services is a little bit different. We do see all the patients that are from all different specialties, so all different diagnoses, but they are just a little bit separated because it is such a unique environment. So typically we don't have floats that come to surgical services.
Yeah, that makes sense. I remember during COVID, talking to a bunch of nurses and some saying like, I got to float to a different unit, which was really actually a nice break from my unit. And I was helping hands and it was, didn't have a full assignment or like actually, hospital organization near here, what they did when they had like all these patients that canceled electives, the nurse practitioners went and helped, did helping hands in ICUs.
Yeah.
So they weren't taking an assignment, but they were, so it was just like in kind of an innovative way, which I thought was cool and it helped them have a little bit of like, okay, I don't have to see 30 patients today I can do something, because they all had worked ICU at some point. So I thought it was kind of cool. But another question I wanted to ask though, because a lot of people hear oncology, they also think, end of life is something like we mentioned earlier that you're going to like run into quite a bit is, and I worked critical care for a while, and that was always a tough thing when you had to deal with that at all, let alone when you had people who maybe were not on the same page. And I never had to do that with a child involved. I had to always do that with adults. And even then it got dicey because not everybody has conversations. And I bet in the pediatric world, not necessarily just the oncology, but pediatric world, those conversations would be challenging. How does your nurses or navigate that kind of stuff? And especially, you're considering things like, who's got, I don't know, custody and that kind of stuff with a child walking through like a cancer diagnosis. Like, how does that kind of stuff tend to like play out, and how do nurses like deal with that?
So yeah, it definitely can be really difficult. Like you said, compared to adults, because they can make their own decisions, and children, it's very different. We have for our patients, it is an institutional policy that the provider has to explain everything to the patient as well as whoever is their legal decision maker. So usually a parent or, could be a grandparent, something like that. So we really want the patient to be on board with everything too. And actually anybody over the age of 14 co-signs their consent forms because we feel like they should be a part of the process. And so we allow them to do that, to have autonomy over their care. We do have an ethics committee that anybody can consult that will come in and give an objective opinion when we do have something that differs. If we have concerns about that. I think because we build really good bonds with our families because they are chronic patients, I think that from the nursing side, it's not as difficult because you can really read the families and can help them in a different way versus if you're just seeing somebody for the first time or just taking care of them 1 week.
Yeah.
I think you build really different bonds with them. But we also have some really unique kind of ways that we help ensure privacy and things when people are on the same page because we do have some programs like our infectious disease and our HIV clinic. We will actually provide care to a minor without consent of their parent in some instances like that. If we're doing some sort of prenatal care or different infectious diseases, that is something that is different than adults because we are providing care without a legal guardian.
That makes sense. Man, so many things you don't like in the pediatric world, you don't have to necessarily touch. I mean, sometimes adults can't make their own decisions, but
And then it's interesting too here because, we see patients globally. So we see patients from all over the world.
Oh,
so
yes.
we have our nurses and most of our staff are very well acquainted with the variety of cultures that we encounter. And so therefore, end of life practices differ depending on, these different cultures. So we have a strong resources in place to help, guide us in those different cultures and different things that we can do to help support them or things that we don't need to do. So that's another big consideration for end of life, especially here, because we do see patients from all over the world. So we have to be very mindful of respecting them and their wishes when we are dealing with end of life, because that provides kind of another layer of things that you have to discuss and make sure that everyone's on the same page.
Oh, yeah.
Yeah, that's a really good point. And it's also kind of difficult during normal care when it's not end of life, just because, there are so many cultural differences that you wouldn't think about. So we have lots of resources on different types of eating preferences, and we will plan ahead knowing, okay, we're going to get a Orthodox Jewish family in. And so we need to know that we need to be able to provide these things for them. So we do a lot of pre-planning when we have patients from different cultures. And so that's really, really helpful. We have a lot of care conferences and have great care coordinators. So we can really be proactive in helping meet their needs.
Oh, yeah. And then if I didn't dawn on me till you had just said it. Like if you're having people coming in long-term over weeks and sometimes years, that is scheduled out. Like it's not like the emergency department where Lord knows what's going to happen today or who's going to walk in.
No, patients have to be accepted here. So once they're accepted as a patient, then they have basically a schedule that they follow for their entire treatment plan.
It's like at college.
So 7 days a week, they either are here or they do get opportunities to go back home. So it's a pretty rigorous process to get them the treatment that they need. But yeah, basically once they're admitted here, like they're on a schedule. So we're able to predict and plan and make those modifications for them as necessary. Because like you said, people don't just roll in like an emergency room. It's very scheduled out to the best of our ability. So.
Yeah, we have our own version of an emergency room, but it's only for our patients. So, yeah, still a little bit predictable.
So that is a very interesting, because I think that is one of the things that is people do like, but also don't like about nursing is you don't know what kind of a day you could ever have. Like, who knows what patients and that and what could unfold, because literally anyone could walk through the door, but you do have this, I didn't realize you have to be accepted. And so there's these are our patients and it's not so that makes sense.
It's on a larger scale. So when you're here day to day, it doesn't feel that way. But since we are research based, these patients, when they're in their hometown and have symptoms and there's a preliminary diagnosis and they get referred here, then they're accepted, into a, protocol clinical trial. So that's how they end up here. So therefore we kind of are able to track and plan and do, because we know who's coming in. And then our acute care clinic, or our quote unquote emergency room for our patients, it is strictly oncology emergencies. So, our biggest threat is sepsis. So any kind of fever, we treat that like it is life or death, because it potentially can be. So any kind of fever, they have to come in. Our sickle cell patients come in for pain crisis or acute chest. So that's typically what our emergency or overnight hours area sees are our patient oncology emergencies. And then, of course, if they have any other type of emergencies, such as they've fallen and they're hit their head and they can't wake up, we encourage them to seek the regular pediatric emergency room, and we're there to support them in that process. And if they need to go there, that we can help facilitate that. But we focus on those oncology emergencies and oncology in their treatment plan.
Oh, that's interesting. So you don't have people coming in where it's like, we don't have a chart. We just have their name.
Unless they slip through somehow, some way.
I mean, the only thing I can think that kind of was like that recently was actually our Ukrainian patients that we took during the
Oh,
evacuation. That was a really cool process to see, and they essentially were sent to us with these charts that we couldn't read.
I bet you
And
could.
yeah, so there was a whole team of people here at St. Jude that were spending night and day translating these medical documents.
Wow.
And thankfully, we were able to receive translated documents, but there are some things, the nuances that a parent's going to tell you that
Mm.
sometimes is a little bit harder to get. You got to get the translator or the phone and those types of things. So yeah, that's the only thing I think recently that's like, we're not really sure what we're expecting.
Wow. That is interesting. Now
Yeah.
to close, I always ask everybody this question. So I'd love to hear if you guys could talk to the version of yourself that graduated from nursing school and give that person 3 pieces of advice and she would listen to them. What 3 things would you tell her?
Gosh.
Or a
To make
couple, just 1 or 2.
mine was to stick out the hard days, because when you look back, the good ones are always going to outweigh it. When I look back, the moments I had where I went home and I was like, wow, I did something really good today, or I did something really good for my patient. I remember those way more than when I look back and I'm like, oh, that was a really terrible day. Like you may remember you had a bad day, but you probably can't remember the details, versus that really great interaction you had, or that, moment you had with your patient that their end of chemo and you got to send them home, or those things. So, to me, sticking out the hard days. So, because the good ones are always going to outweigh in the long
Cool.
run.
Yeah, totally. I think mine would probably be something about like, don't be scared to be yourself. I think
Mhm.
you get really nervous going in, being a new nurse and meeting new people and learning a new profession that you forget, you can be yourself. You can wear mismatched socks. I used to get made fun of because I used to wear wallabies to work. And, and I was a little self-conscious about that, but then it's like, no, like I would want to tell myself, like, be yourself, like, do you, and it's going to help so much in the
Mhm.
long run.
Yeah.
Yeah, maintaining that sense of identity. I mean, just like you wanna fit in, but you also don't wanna sacrifice those parts of yourself that make you who
Yeah.
you are, uniquely who you are, and that is tough when they're going into a new environment, starting nursing school or starting a new job. You wanna fit in so bad that you can, like, downplay or not do those things that are
Hmm.
actually a cool part of yourself. So that's a
Mhm.
real
Yeah. No,
really
definitely. That's one thing I love too about our work is we don't have uniforms, which is, I feel like, really
Yeah,
rare.
Oh, yeah.
nice.
So
We wear
we are
fun
all
stuff.
about expressing your personality. So yeah.
Yeah,
Oh,
that's
that's
like a hot button topic for new grads. What is the uniform? And we get to
Mhm.
say you get to wear whatever St. Jude t-shirt you want to wear with your scrub pants.
Yeah.
So,
Oh, that's
um,
wonderful.
very friendly for the staff and for the patients as well.
Man, Pete's
Definitely.
has such nice you get fun units with toys and, like, adult units look so sad, and so do we
Yeah,
with our, like, boring scrubs.
every one of our units is a different theme, and it makes
Yeah.
noises, and the walls are all different colors, and it's really, really
Oh,
cool.
Yeah.
yeah, I wish they did that in adult units. I think it would be so sad.
Oh my gosh. Yeah. I know. It's like, I'm always like, why does it have to be white? Like, can you liven up the walls a little bit?
Yeah, yeah, like, make this not look so I mean, I know you want it to look sterile, but not sterile at the same time. I don't
Yeah.
know. I don't design, but I don't know. Pete's floors are so beautiful and fun, and it's probably I like, just as a place to work, is probably more, enjoyable to just, like, walk into an environment like that instead
Mhm.
of, your regular old hospital.
Yeah.
Definitely. It's one of those things you sound so cliche saying it, but like it's so easy to stay connected to our mission because we see it every single day.
Yeah.
It's on the walls and you see the kids playing. And that's something that for me has been really a lifesaver, honestly, in my career when I'm having the bad days is to be able to look around and see the fruits of your labor. And and I'm so thankful to have had those experiences.
Mhm.
So
Yeah, seeing that in real time is really
Mhm.
validating, especially with all the hard work that you go through to get to that point. I
Yeah.
think that's something we need in our professional life. So that's man, how I mean, as hard as the hard days are, like you said, like, oh, I've thought of things that I've done that have made me really proud to be part of that with a patient. But like you said, in the inpatient world, you're maybe a week. I mean, the longest I had one patient, I think the longest was maybe a month. But it's
Yeah.
like having those long-term relationships while also getting to do complex clinical stuff at the same time. And it is kind of a unique place because you may have work in an outpatient clinic, but you don't see the same, it's not like you see them regularly enough to build a relationship, but this is like a different ballgame where you get to see them more regularly and
Every
you get
day.
to do a whole bunch of cool stuff.
Oh
Yeah.
my gosh. Yes. Yeah. Our outpatient clinics, especially, are nothing like working in a doctor's office. They're
No.
super high task because we send a lot of sick kids home, whether that's their house in Memphis or that's one of our St. Jude housing
Mhm.
facilities. We'll send a kid home when normally another institution might keep them inpatient. And so our outpatient nurses are really highly skilled. And I think that's something that people coming into St. Jude are so surprised about.
Yeah, because I mean, in adult clinic, no shade to adult clinics, but that's a lot of telephone work. It's not very task heavy in
Yeah.
terms of like clinical task. It's
Mhm.
clinical knowledge and what you're doing like on the computer and coordinating and lots of phone calls, but it's not like, physical tasks usually with those patients. But well, thank you both so much for your time. This was a wonderful and very enlightening interview of
You're welcome.
area of nursing I know very little about. So very much appreciate both of you and your time.
Yeah,
You're
thank
welcome.
you. This
Thanks
was
for
great.
having us. Yeah, no, we're always so excited to share about, what we do because we're lucky to be super connected to what we do every day.
That's great. That's wonderful. Well, thanks nurses for listening and stay fresh. Thank you guys so much for listening. And to learn more about St. Jude's and their program, I do have a link in the description of this episode. And if you are interested in learning more about my nurse residency program, it is self-paced, completely online. And that's for people who maybe they don't have a great residency program, or maybe you're one of the many people who doesn't have a residency program at all. Or maybe you're a graduating student and really want to like get a head start on what to expect as a newly licensed nurse. And also, if you're at that point in your development, I really recommend you going all the way back to episode 1 of the FreshRN podcast. We walk through orientation, what to expect, and how to navigate that. They're evergreen episodes, so they continue to be applicable today, even though we recorded them a few years ago. So I definitely encourage you to do that if you find yourself in that particular part of your nursing journey, and highly recommend getting on my email list so you can get some weekly tips and tricks from me and learn from all the mistakes that I have made over the years, as well as others. So to get on my email list, you'll head to FreshRN.com and just pop your name and email in, and you'll be getting weekly emails. If you are interested in learning more about my residency program, I also will have a link to that in the description of this episode. Thanks, nurses, and stay fresh.